Welcome to the podcast, Dr. Rick Chazelle and Dr. Jim Min. It's great to have you join us. We like to start each episode by hearing about your organizations and how you work together. Dr. Chazelle, would you like to get us started?
Sure, and thanks for having us today, Leon. I'm Rick Chazelle. I'm a clinical cardiologist, and I'm the medical director of the Heart and Vascular Institute at Lee Health System. Lee Health is a 5-hospital county hospital, not-for-profit public hospital system in Southwest Florida, serving a catchment area of roughly 1 million people.
Dr. Min, can you tell us a little bit about yourself and your organization?
Sure. Thanks so much for having us on the podcast today. So I'm Jim Min. I'm the founder and the CEO of a company called Cleerly. We're a mission-driven company who aims to personalize heart care so that we can try to identify and get people treated as early as possible, those who are at risk of a heart attack. Prior to my life at Cleerly, I'm also a clinical cardiologist with a focus on non-invasive imaging. Practiced for about 15 years at Cornell Medical College and New York Presbyterian Hospital. And it's during that tenure that I met Rick and we had the pleasure of starting to work together. So thanks for having us.
That's great. We know that cardiovascular care in America is really important. It's one of our leading causes of death in many populations. Can you tell our listeners about the historical approach to cardiovascular care?
Yeah, I think that's a great question. The historical approach that we've done to evaluate patients with suspected heart disease has relied primarily on symptoms of chest pain or symptoms of shortness of breath. What I was taught more than 20 years ago training was that it was the symptomatic people who present who are at risk of heart attacks, and that if we can relieve their symptoms, we can reduce their risk. What we found out over the last 20 years and probably 7 large-scale randomized controlled landmark trials is that actually isn't true. Like in a symptomatic person who presents with chest pain, treating that patient relieves their symptoms but doesn't necessarily reduce their risk of heart attacks. So, it's time for a change, and we need to stop conflating both of these two questions and extricate them, and realizing that treating symptoms is very important and reducing risk of heart attack is an entirely different one. The way that we approach these, we're really from more population-based approaches where we can compare 1 million people to another 1 million people and look at differences, and we can find a sicker 1 million people versus a healthier 1 million people. What we don't do well is find within those 1 million people the ability to pinpoint with precision who is sick and who's not, who deserves therapy, who deserves enhanced and intensified treatment. And it's that sort of personalized healthcare that I think the field is now just entering.
That sounds really incredible. This notion of precision heart care is really an innovation, if you will, in the field. And can you tell me, Dr. Chazelle, how are you implementing this change, this movement towards more precision heart approach where symptoms may be identified, but reducing risk is really the goal?
Jim really explained to you that we've based everything we've done heretofore on statistical models from populations, or what we call surrogate markers, that suggest the likelihood of someone developing plaque and then developing a heart attack based on statistical estimates. But what we're doing now at Lee Health is we're migrating toward the idea of looking at individuals, looking at their arteries, and looking for the development of plaque. So we're not looking at risk factors now. We're not looking at statistical models. We're looking at really whether or not the individual has plaque. And importantly, Leon, we're looking at how much plaque is there and what type of plaque it is. That allows us to initiate therapeutics before one of us gets to the point of having symptoms, and also, importantly, allows us the opportunity longitudinally to be able to measure the changes brought on by our therapeutics. And we're doing this in our healthcare plan for our own employees. So we're looking at our own employees and trying to prevent heart attacks there, with the intent of expanding that further into our populations for whom we care.
Have you had any early wins, any things you'd like to share in this moment about, since you're putting this in play and implementing with your population, what have you found so far?
Well, it is interesting. First of all, we've been surprised that a significant proportion of our employees have some early plaque and didn't know it. On the other end of the spectrum, we've had some that had a lot of plaque and were not aware and needed aggressive therapy. We've had a couple of people that we've identified that had severe blockage that we felt was in a location and of a type that placed them at high risk and put us in a position to try and intervene early to prevent it. And we've had the occasional patient in whom we found something else that wasn't in the arteries to the heart, but was in the aorta or other places that's helped us counsel, treat, and then follow up these people. So it's been very helpful. And I think the visual that we're giving our employees and our patients allows them to actually see what's going on in their arteries. And it's a strong impetus for lifestyle change or for taking medication to reduce risk.
That's a really strong hypothesis, which I would say, as a person who's at risk for a cardiovascular event at some point, given my family history, one thing I really like about this is this notion of an individual treatment and being able to provide individuals a sense of their own health and probably some empowerment around their health as well.
Leon, if I can interject here, let me say
Sure.
that you're statistically at risk because of that. But if we did a scan on you and actually showed you your arteries and showed you that you were developing plaque, the likelihood of you being really careful about lifestyle modification and carefully taking your medication becomes very personal. It's no longer a statistical likelihood of disease. You actually know what's going on in your own arteries. It's very compelling.
And Dr. Min, can you speak a little about, as a surgeon yourself and really being at the forefront of this approach, can you tell more about how you see this really being able to help a range of different communities take some care or a different approach to their own care, like even as a patient or a provider? How has this impacted, you think, or how will it impact?
It's a really good question. I think just dovetailing on what Rick was saying, I think that what the field of cardiology has done exceedingly well is to hold itself to a high standard of scientific evidence generation. But in doing so, what we do are these large mega trials, like these clinical trials of 30,000, 20,000 people. And what we noticed is that whole concept of a big data approach to things, I think that what we're now trying to shift towards, or at least expand upon, not replace that, but expand upon it, is this concept of small data, right? So nobody ever talks about small data. They always talk about big data. To me, what small data is, it's an interpretable understanding. It's N of one medicine. And I think where small data is very good is where you have conditions that are dynamic, they change over time, that are multi-causal or polyfactorial, and that they're idiosyncratically manifesting phenomena, right? So like most of the people who have heart attacks don't have symptoms, and we don't know whether they're shoveling snow. There's a lot of individual situational things that really contribute to this. If we can adopt this concept of small data, the N of one medicine, then we can follow the model that the cancer diagnostics has done, right? Nobody would ever start treating a breast cancer without understanding whether or not it's estrogen receptor positive or negative. You can only get that at the individual. And so I think what we're trying to espouse is, let's measure individual disease, not population-based indirect markers of disease. And what was interesting is that in a series of publications that have come out from very large-scale trials, when you do that and you start to list out the features that are important to predict important patient-centered outcomes, what you realize is that the top 20 features are all related to disease features. And then number 21, 22, 23, and so on, are you old or young? Are you black or white? Are you young or old? What you realize out of that is that by individualizing the care, you end up democratizing the care, because you look at that individual for the disease that they have rather than the disease that they might have, as evidenced by some of these population-based approaches. So it really transitioned the field towards away from measuring indirect markers of disease to actual heart disease itself in a personalized diagnostics approach. I think that's the paradigm that we're trying to push forward.
From both of your clinical experience, you use some really important terms like a small data approach, expanding the concept, patient-centered outcomes, and democratizing care. It almost sounds like this approach of precision heart care could really be an avenue to equity in cardiovascular care as well. Can either of you speak to that?
I think there are a couple of aspects to that, Leon. The first is that much of the large data that Jim has alluded to is based on randomized trials that have a predominance of white males, white middle-aged males. And it means that we have a lot less data on which to draw both diagnostically and therapeutically with other populations, ethnic, age, gender populations. So we're basing a lot of the treatment on someone that just looks the same as I do, perhaps, and that's not good. The second is that some populations are not advantaged with regard to education and perception of the relationship between risk factors and actual disease. And by taking an individual and showing that person exactly what is going on in his or her artery, you're beginning to bring it down to a level that any of us can very easily understand and relate to in a way that changes behavior and improves care. So we really are pretty strong on this. And what we've done at Lee Health is to make certain that we're delivering that same opportunity and the therapeutics, by the way, that back it up to employees across the spectrum, regardless of what their background is, so that they are able to take advantage of this.
Yeah, I couldn't agree with Rick more. I'll give you an example. This is not necessarily directly related to equity, but it is emblematic. Like we have in our field, we call diabetes mellitus a coronary heart disease equivalent. That means that we assume that somebody with diabetes has heart disease until proven otherwise. But when you do the population-based study, nearly 2 out of 3 people with diabetes don't have any actual disease. So what we're labeling sort of as a general form for diabetes it sort of disengages us from the person that we're labeling. And if we actually look at that individual's disease, then we don't have to come in with these sort of biases. So we're trying to personalize the care so we can establish the equity. And I think more importantly than just making the diagnosis, we have to deliver tools like educational health literacy tools to patients to meet them where they're at, so that we can empower each and every stakeholder in the care pathway, whether that's the physician or whether that's the patient. And then we have to try to do it in a way that is sort of culturally and educationally acceptable to that patient in a way that maximizes their health literacy.
Earlier this year, the Institute for Diversity and Health Equity released the Health Equity Roadmap. One of our 6 levers of transformation is culturally centered patient care. How would you apply precision heart care approach to culturally centered patient care strategies for our member hospitals?
I think the easiest way to democratize care is to individualize it. Let me give you the example of 2 patients. You've got a young Asian woman who's vegan, a yoga instructor, and you've got an older Caucasian hypertensive diabetic patient with dyslipidemia and high cholesterol. So one would say the second one has to be sicker. They have all of these risk factors. But as we've discussed earlier, we don't actually know that with precision until we actually individualize the care and take a look at that patient's heart arteries themselves. And it turns out when you look at the prior large-scale studies, that if you took those 2 patients, but they had the same amount of disease, they would have exactly the same prognosis. So if you want to democratize care and get rid of biases, then you should just individualize the care. And then in addition to that, once you make the diagnosis and the prognosis is the same, what you then have to ask is their reaction to treatment going to be the same? And the answer is probably not. And so now we have a safe, non-invasive tool to be able to individualize whether or not we've achieved therapeutic success, or in the case of therapeutic failure, to use actual disease to help us guide when we should intensify therapy or consider other options.
We believe that the model that we're using currently in Southwest Florida may be exportable to other places where they have populations for which we're responsible for not only their care, but also the cost of care, because this, we believe, it can be a cost-effective approach. So I think it's exportable in that manner. But beyond that, I also see this as a vehicle for collecting information in the long term that may help inform some of those areas of question that we don't understand yet. What are some of the relationships, and eventually get better ideas about the data for treatment of all these patients.
Dr. Min and Dr. Chazelle, thank you for joining the podcast and sharing this exciting development in cardiovascular care. To learn about the Health Equity Roadmap, please visit equity.aha.org. This has been Advancing Health, brought to you by the American Hospital Association. Thanks for listening.